The incidence of anorectal trauma varies between the military and civilian literature. A study that looked at colorectal injuries during Operation Iraqi Freedom noted a 5.1% incidence, and that incidence in the civilian literature has been reported at 1 to 3%. The pattern of injury associated with military injuries is usually from high-velocity gunshot wounds or blunt injury related to a blast. That from the civilian injuries results from penetrating low-velocity gunshot wounds in greater than 80% of cases. The other 20% comes from accidental or intentional impalement, rectal foreign body trauma, rectal injury from blunt trauma related to pelvic fractures. Anal trauma is relatively uncommon. In a report by Glasgow and colleagues, he looked at anal trauma during the Iraq and Afghanistan wars and noted a prevalence of about 0.2%. And they noted that the signature injury during these wars was complex pelvic-perineal trauma caused by ground-level improvised explosive devices. The management of especially rectal trauma has evolved from our experience in the military. So during the Civil War, most patients who had some sort of colorectal injury died because of their injury, secondary to infection or septic complications. And so expected management was kind of the rule, and there was a mortality of greater than 90%. By the end of World War I, they were doing more early exploration and diversion, and the mortality dropped to about 60 to 75%, although this depended on the location of the injury. By World War II, we were doing mandatory colostomies, and we'd had improvement in our mortality due to the use of antibiotics as well as better resuscitation of our patients. So the mortality is less than 30%. In a landmark paper by Lavinson and Cohen, looking at management of these patients during the Vietnam War, led to the standard management of rectal trauma with diversion, presacral drainage, direct repair of the injury, as well as a distal washout. And they reported a mortality of less than 15%. Traumatic anal injuries remain poorly characterized, and when they are reported in the literature, they're usually reported and associated with rectal trauma. Although there was a report back from World War II, McCune and colleagues noted that 11 of 41 patients who had anal trauma regained sphincter function with just gluteal and sphincter muscle exercises alone. But most of the studies on non-obstetric anal trauma focus on late management repair. There's a few studies that are actually in the literature looking at the acute management of these injuries. So the initial management of patients who present with anorectal trauma follows ATLS principles. We usually are looking at anorectal trauma and assessing it during the secondary survey. A digital rectal exam is performed. Anybody that has gross blood mandates further evaluation with proctoscopy or sigmoidoscopy. Some studies have shown that this digital rectal exam is only about 33% sensitive for rectal injury and 6% for all ball injuries. Other modalities that we use is triple contrast CT scan, and this is the one that's standard now for evaluation of trauma patients. But in a study of 104 patients evaluated for peritoneal vilation or colonic major vascular urinary tract injuries after penetrating trauma, found that this modality was 100% sensitive, 96% specific, and demonstrated 97% accuracy in diagnosis. Diagnostic peritoneal lavage, while not routinely performed now because the sensitivity and specificity of CT scan is so high, has shown in the literature to be about 84 to 97% sensitive for detecting bowel injury. Classification of these injuries is according to the American Association of Surgery of Trauma Organ Injury Scale. So they're classified on a grade of 1 to 5, with 5 being the most severe injury with a devascularized segment. The management of anal rectal trauma depends on several variables. One, especially for the rectum, is this intra versus extraperitoneal? Is the injury destructive versus non-destructive? Are there any associated injuries? And then, of course, the clinical status of the patient. Are they stable or are they in a state of shock? So looking at those kind of the 4Ds that were, the dogma with regards to treatment of rectal trauma, and, do we still do this today? Should it be done today? So should all rectal injuries be managed with proximal diversion and direct repair? Intraperitoneal injuries can universally, it's accepted that they can be treated like colonic injuries. Primary repair, if they're non-destructive injuries, they involve less than 50% the circumference of the bowel, and there's minimal fecal contamination. Those patients who have destructive injuries should be treated with resection and primary anastomosis, plus or minus proximal diversion or an end colostomy, and this depends on the stability of the patient. In 2018, the American Association for the Surgery of Trauma published the results of a multi-institutional study involving 22 level 1 trauma centers looking at patients who sustained rectal trauma. They collected data on mechanism of injury, location of the injury, management of the injuries, and they looked at outcomes. Their primary outcome was abdominal complications, specifically abdominal, pelvic, or retroperitoneal abscesses, as well as fascial dehiscence, and then their secondary complication was looking at mortality. They note that in this study, patients who were treated with proximal diversion had more abdominal complications. With regards to extraperitoneal injuries, there's a little bit more debate with this. These injuries tend to be associated with additional genitourinary, vascular, bony pelvic injuries, but I would say most of the literature supports proximal diversion. Where the controversy exists is primary repair of the actual injury necessary. This can potentially be a complex exposure to try to gain access to the injury site. There's limited mobility within the pelvis. Multiple studies, though, have shown that there's no difference in the overall morbidity and mortality if the injury is repaired, if the patient is already diverted. So if the patient is diverted, primary repair is not necessarily needed. We come to the use of presacral drainage. Again, this was advocated for after the Vietnam War, and the civilian literature since that time has called into question the use of this as well as rectal washout, which we'll talk about in a minute. But should presacral drainage be used in all extraperitoneal injuries? This involves dissection and disruption of normal tissue planes. Gonzalez and colleagues published a prospective randomized trial of 48 patients with rectal injury treated with diversion and drainage or just diversion alone. And they noted that there was no improvement in infectious complications in those patients that had presacral drainage. And again, this AAST rectal trauma study found that there was a 3-fold increase in abdominal complications in patients who underwent presacral drainage. Now looking at distal rectal washout, should this be performed? Proponents of this say that this clears the rectum of stool and that can be a source of sepsis. Those who are against it say that flushing the stool can force stool and bacteria into the tissue planes. And the AAST's trauma study, again, found a 3-fold increase in complications in patients who had rectal washout. This looks like a busy slide, but kind of the key points here is with regards to intraperitoneal injuries, if it's destructive versus non-destructive, primary repair for non-destructive injuries and those that are destructive should have some sort of resection, and whether or not you anastomose or bring out an end colostomy, it depends on the patient. And then with regards to extraperitoneal injury, usually diversion. And they note presacral drainage, distal rectal washout, and direct repair can be left up to the discretion of the surgeon because there's lack of evidence supporting the use and benefit of these modalities. With regards to anal trauma, there's little in the literature regarding, again, like I said, the acute management of anal trauma. The literature looking at sphincter repairs notes that about 5 to 15% of sphincter repairs are performed for non-obstetric trauma. Glasgow and colleagues in 2014 reported on anal trauma that was in patients in the Iraq and Afghanistan wars. They looked at 46 patients total. 80% of these patients got a proximal diversion. Almost 23% underwent an attempted acute repair at the time of their injury. And of the 80% that were diverted, 30% had a permanent colostomy. Long-term colostomy was associated with concurrent abdominal injury, hypogastric arterial ligation, and pelvic fracture. They note that the long-term functional outcome in those patients that were reversed assumed to be adequate, as the no patients required rediversion. So they recommend that in the acute setting, no anoplasty or reconstruction of the sphincter complex be attempted. They do recommend marking the ends of the sphincter for possible future repair and trying to reapproximate the anoderm. Trauma, I thought I'd talk about trauma specifically related to rectal foreign body, because this may be something more common to see, as they are a common presenting complaint to the emergency department. Epidemiology, this is usually in males age range from 18 to 40 years old. Reasons for insertion, sexual reasons, attention-seeking behavior, assault, alleviation of constipation. These patients may present immediately once they realize they're unable to remove the object. Others may wait days or even weeks. The diagnosis and evaluation of these patients begins with a history and physical. On exam, you want to look for peritonitis, as this is going to dictate likely operative management. A digital rectal exam should be performed. You should evaluate the proximity of the object to the pelvic floor, and also evaluate and document the sphincter function. Several imaging modalities can be used, but may not be necessary, but plain film or CT scan, rigid proctoscopy, or flexible sigmoidoscopy. If patients appear to have peritonitis or hemodynamically unstable, they should go to the OR immediately for an exploratory laparotomy. If you're attempting to do a transanal excision, you can try this in the emergency department. Some tips for doing that is to try local anesthesia and also some sort of sedation. But bedside extraction is successful in 60 to 75% of patients. Tried in the lithotomy position, applying sigmoid or suprapubic pressure. There's several tools you can use to grasp the object, but the main take-home point is you want to break that vacuum seal that's kind of sucked the object up into the rectum. You can do that with a finger. Otherwise, people have noted using a Foley catheter, putting that up above the object, inflating the balloon. That'll break the vacuum seal, and then you can use it to pull the object down. Other modalities, you can use endoscopic extraction, use of snare or biopsy forceps. But ultimately, you may have to take the patient to the operating room. So if you go to the operating room, start with an exam under anesthesia. The general anesthesia itself may cause enough relaxation of the pelvic floor muscles then to allow for transanal excision. If you're unable to get it out transanally, you can try a laparoscopic assisted guidance to try to milk the object back towards distally to allow for transanal excision. But ultimately, all these measures fail, performing a colotomy with a transabdominal extraction, and then with primary closure of the colotomy. If there is any evidence of contamination, either resection and anastomosis versus a Hartmann's procedure. This is that same study group that I was talking about before the AAST. They specifically looked at trauma after foreign body insertion. Again, 22 level 1 trauma centers. They had a total of 33 patients. 11 of these patients had full thickness injuries, 22 had partial thickness injuries. They specifically looked at the patients with partial thickness injuries. About 8 of these patients required operative intervention, ranging from proximal diversion, direct repair with proximal diversion, and direct repair alone. They noted that patients who had partial thickness injury who had operative intervention had a significantly longer hospital length of stay and noted to have more complications, although this was not statistically significant. So they recommended that non-operative management after retained rectal foreign body, unless there's a full thickness injury noted or conclusively identified. What do we do with these patients after you've removed the object? Some advocate a period of observation, but this will depend on the clinical status of the patient, the size of the object, if there's any resultant trauma. Some sort of endoscopic exam to evaluate the anorectal mucosa, either by rigid procto or flexible sigmoidoscopy. Antibiotics are not necessary for simple extraction. And then you do want to document sphincter function. If they do have issues, a delayed repair is possible if they have issues with fecal incontinence. I would also mention that if this is a recurrent problem for a patient, consideration of some sort of psychiatric evaluation. In summary, patients who have intraperitoneal injuries to the rectum can be managed as those who have colonic injury. Those who have damage to the extraperitoneal rectum should have a proximal diversion. Rarely would you need to do a primary repair, and there's no strong recommendation for presacral drainage or washout. Those with anal trauma should have a primary repair for simple, clean wounds. If they have a destructive injury, debridement of the devitalized tissue with proximal diversion is recommended. And then for rectal foreign bodies, non-operative management unless there's a full thickness injury identified. Thank you.